And this was done as a one-stage procedure, even though it's a bone level implant. I mean, I am in a, sometimes I'm lazy in the sense that I don't want to go back in, give anesthetic again, make an incision and open it up, and then expose the implant and start to condition tissue. I want to cut down the length of time that I'm going to have to do in order to get from my start to my finished product. So there's the internal, that internal hex implant. And you can see here, like, you can see all this. And the reason there's so much here is because, again, my incision, when I went to put I didn't make my incision right here. I made the incision clear back here, pushed all that forward, and then butted it up against the healing. And you really don't have to be meticulous with your suturing. It just seems like Mother Nature prevails and it all heals up. Again, I said this before, I think in a way suturing is a little bit overrated. And this just happens to be a different type of a button, what's it called? This was a Cybron implant. It was a Pit Easy abutment. Then there's our final crown. But it's centered, and the position of the implant allowed me to create the crown just using a simple stock abutment. You screw the stock abutment in. Because it was in the right position, you didn't have to get too involved with the prosthetics. So you can take that idea of the surgical guide and you can expand it based on the number of actual implants that you want to place, especially, you know, in the aesthetic zone. So someone asked me, well, you had a patient come in, and the patient came in, and they had a list of 4 implants. What implants do you place? Do you place any of these 4 implants? And Noble BioCare was one of the implants. And you said, no, I don't use that implant. So the patient said, okay, goodbye, and they left. Well, you know, if you flip a coin, heads, tails, it can land either way. On the other side of the coin, this is an interesting story. This person here goes and has this implant placed. It's a Noble BioCare implant. And he paid a very, very high fee to have that implant placed. And just so happened that I placed an implant on his neighbor. So he comes back to see me and says, oh, hey, I want you to put this implant in here. I said, well, you know, you already have an implant in there. Yeah, I had the implant placed by a periodontist, but, you know, I can't believe how much he charged me for that implant. He goes, I want you to place it. I said, okay, fine. So the patient did not want to pay as much money. And I'm putting an implant in that's not one of the big four implants. But that patient was concerned about the cost. That was the most important. So I mean, I don't think you can be all things to all people. There are going to be a certain number of patients that don't like the way you look, don't like the way your hair is. They're going to go somewhere else. Don't like your receptionist. Don't like the smell of your office when they come. You can't be all things to all people. So again, I wouldn't be concerned about that. But in this particular case now, I'm saying to myself, well, I got to get this implant in here. And I got to get that implant in there so it's in a good position. And I got to get the implant in, and I didn't have a CT done. So if you look at this, you would say, oh, is that implant in the sinus? Or is that implant buccal to the sinus? So if this is the sinus, the implant could be right here, and you're not in the sinus, right? Or it could be here, and someone went in and did a sinus lift. You don't know. I mean, that is the advantage of the CT before you get involved in something like this, because then with a CT, you can look this way, You can see how wide you have and how much height you need. But the CT costs some money to have done. Okay? Or you could drill down so many millimeters, and take an x-ray, and know how many millimeters you drill down, calculate, then make a determination on where you are in reference to the sinus. And it only takes a couple minutes to do that. And for some people, you know, they don't have, again, economics all comes into play. Technology is great, but sometimes technology is really expensive and it forces people not to have. Some dentists would say, well, I can't put that implant in there unless we have a CT stuff. And another implant, another person like myself would just go ahead and put the implant in and not be concerned about it. So you want to keep your 3 millimeter space, if possible, between your implants. So here's the Noble BioCare implant. So I got to put my implant in right here. So in order for me to place the implant, you know, once you make your incision, you open this up, sometimes you lose your reference a little bit. So I know you've seen on some of the other cases where I did the flap design with what's called a papilla-saving incision. So you start right here with your incision. You don't do a sulcular incision here. You start here, and you come back that way and across, and then you flap it. So one advantage of leaving tissue here is you leave yourself space, so you can keep your dimension away from that tooth. It's just like a reference for you, as opposed to making your larger incision. So, do you think you need to dim those lights a little bit or not? Can everybody see that okay? So, this is my guide that I use for this, and this is a different way that I made the guide. I make guides a lot of different ways, but this is a .040 material. Do you have Invisalign for orthodontics here? Invisalign? Okay, so it'd be about that thick. It's an 040 material. So I modeled it over the top of, sucked it down over the top of the model, and then prior to doing that, I marked on the model in pencil where I want my implant. I sucked that down. Then I take a round burr, just drill through the guide with the stop, position it in a model. Then instead of using the putty, I just flow the injectable gel around that, put it in the oven, and it cures. So the gel here will bond to that Invisalign, into that 040 material. So that's what I end up with. So based on this, you can do this a couple different ways. You can take a little pointed burr, like a pivot burr or a needle drill, and like in some cases where you have numerous things in the anterior region, you can drill through here and score the bone before you lay your flap. So then when you lay your flap and you look at it, you say, oh, there's a hole, that's where I want to put my implant. So you can use this idea without using a drill stop, without using that, just by making your horizontal position of where you want to do it, where you want to place it, and just drill with your drill through the tissue. You're only going like 0.2 of a millimeter diameter of that burr. Drill, score the bone, then lay your flap, then you have your orientation of where you are. So in this particular case, this was just a round burr. This was my drill stop here, and I'm placing this type of this 10 millimeter deep implant. So the sinus was the concern, so I set this stop and I measured from here to there, 5 millimeters. So then I laid my flap. You can see the flap is already laid here, and I just go right through 5 millimeters. Then I just take an x-ray. So I'm 5 millimeters away, and I could put an 8 millimeter implant, I could put a 8 millimeter implant in there. So there's my finished implant. This is the, I think it's 8, maybe, I can't remember here. But anyway, I drill right to the base of the sinus, based on, my calculation. Now, if you wanted to do a little crestal sinus bump, you could do that, or you could stay away from the sinus. So then there's my implant in place, and with that guide, you can see how parallel these are. I'm not going off at an angle. I mean, you can do this free-handed, and my ego tells me I don't need a guide, I can just do it free-handed, but I personally use the guide because I think my work is better when I use the guide. Because it allows me to keep everything centered where I have planned it. And then again, just suture it up. Hey, Johnny, you sell these cytoplast sutures, don't you? From Osteogenics?
Cytoplast.
Yeah, these are great sutures. It's like a PTFE suture. I mean, you can put those things in, and you can leave them in there for 3 months, not even take them out. And there's no bacteria accumulated around. They're really, really nice sutures. And you can see here, I started right here, push it on, and this just happens to be, someone was asking me, which implant do you like better? You like the tissue level, or you like the hex implant, or you like the trilobe implant? This particular implant is the internal hex implant. It's the Blue Sky internal hex. And there it healed up. So this is the blueskybio. This is the Blue Sky. This is the $1,000 implant. This is the So take an implant level impression and make our custom abutments. And do you use Emax here much? Emax crowns? I like the Emax crowns, and now they have the CAD-CAM all zirconia crowns, which are nice too, and they're less expensive. So I've been using more of the Emax, and the only downside is if you're using the abutments, I have a laboratory technician take and just put opaque over the abutment. So it puts opaque over the abutment so you can cement the Emax crowns over them, and they look fine. Now, sorry to say that in order to get tissue up to here, it's impossible. If you think you want it up there, good luck, but you just can't do it. Because this tooth was gone, this implant was already in here, and that was down, so I may get a little bit of fill over time, but you're not going to do that. So it's one thing you always have to be aware of when you're getting involved in implants, especially in the aesthetic zone. And you tell the patient to grin as wide as they can, and if you know, okay, you're not going to see where that implant is, you got a margin of air there. But if they have a really, really high smile line, that's extremely challenging. Those are the cases I like to refer to someone else. So, the benefit of the surgical guide here is that it helped me to position my implant mesial-distal buccolingually. It aided me in determining actually what length I was going to use in that. So the guide is made around the drill stop. So here would be another case, a posterior case, that the use of the surgical guide aided me immensely in positioning my implants to make the restorative work straightforward. So this person had a bridge in. This tooth here was lost, and so extracted it. We just cut the bridge off, and we left that tooth in there. So you kind of give an idea of where do you think you want to place your implants. Depending upon know, like when you go play poker and they deal the cards, you got to play the cards you're dealt with. You can't turn them back in and get new cards. So when the patient comes in your office, the bone is where the bone is. You can't tell them to go away and come back and send your friend that's got better bone for me to place my implant. You have to deal with it. So I thought, well, it'd be probably better to place an implant here, an implant in a 3 and a bridge. I mean, like if I opened it up and bone wasn't decent here, you know, maybe you could put one implant here, and one there, and then cantilever off, or you could cantilever off and cut a rest rep. There's all different kind of ways that you could go about doing it. But this is the kind of like the plan that I had in mind, or ideally what I wanted to do. And so this is the guide. Now this is a different kind of material that I used. This is when you do a denture, and you know you make a base plate, a stabilized base plate. That's a light cure type material. So this is easy to use because it's soft. You just form it around the drill stop, and then you put it in the oven and you cure it. But this is like working in the back, so I'm thinking, okay, I'll put some grooves in the side of it, so when I go back in the mouth, it's easier. So, and again, you know, I like to use that. In this particular case, in the back of the mouth, it's a little bit more difficult sometimes to keep the guide in there through the whole surgery. So set this drill stop at 5 millimeters, and here's my finished implants. And you can see that the implants are basically centered right under where, you know, the guide, where my plan was to place the implants. And then there's the finished bridge work. And I could go back and show, again, this, you have a nice zone of connective tissue here, whereas before it was up, there wasn't as wide of a band of connective tissue. And that's the advantage of taking and making your incision to the lingual, pushing everything over to the labial or buccal, and then placing your implants. So another case that patient definitely had some problems, and we're going to extract this tooth here, then I'm going to place an implant here. I'm doing an immediate here and a single here. And then I'm also putting a third implant because the patient, I said, well, I can do it a couple different ways. I can make 2 implants and make a false tooth in the center, or we can do 3 implants, so you can just take dental floss in between it. And so kind of sometimes the way you present things to patients, they don't want, that's because, you know, you have to keep these things clean for your lifetime. So it's a lot easier to take the floss down this way than take these little things and thread underneath it. So, well, okay, I'll have the 3 implants placed instead of the 2 in the bridge work. So there's my surgical guide, and here's my 3 implants that I placed. And so now you've got 3 different kind of implants placed here. You've got, this is a Cybron implant. This is a Cybron implant. It's got a hex. This is a bone level implant. And this is an implant that I started using, and now they're going to manufacture this implant because Cybron was bought out, Cybron bought Implant Direct. And Implant Direct is discontinuing the use. And what I thought, the reason I started using this implant, because this implant here has a synocta. So I can take anything that I have that's my Straumann parts and put in here. I can take anything that I have my Blue Sky and put in here. And this is a Blue Sky implant. And this is a wide neck implant. And this is a regular neck implant. But the difference between this implant and this implant is basically a bone level implant. And this is a tissue level implant. So, but the disadvantage of this is you've got to have a wider ridge because you've got 4.8 has to go all the way down. So this one, 6.5 sticks up above the ridge. So you don't need to have as wide a ridge in order to place the implant. So the implants healed up. And these, for anybody who uses, Blue Sky implants, these are abutments that are screwed in. So these are solid abutments. So then you just go through the process of taking the impression and fabricating the crowns. And so this patient was a kind of particular and expected. It's amazing how people end up with these dental problems through neglect. Then they want to be perfect again, and sometimes it's difficult to make it that way. Well, if I'm going to be spending all this money, I want it to look just like natural teeth in there. So these are zirconia copings that the Emax crowns are cemented over the top of this. So this is cemented over the abutment, and then a crown is cemented over the top of that. And there are the final crowns. And she can floss through those. And again, the implant margins down here, you lift up with the zirconia, these were kind of milled, and then these are the crowns that go over the top, and there's my finish. But again, and I told her that probably back here you're going to see a little bit of metal. Okay, if it's clear back there, I don't care, but there's the finished crowns. So with that in mind, what you want to do is always, again, start with the end and work backwards. So this is a patient that had severe periodontal disease, splaying, drifting of the teeth. It's impossible. All these 4 incisors have to go. So the 4 incisors had to go. We extracted the incisors, and we made like a temporary flipper to wear in the interim period of time in order to let the tissue heal prior to placement of the implants. Now, this is definitely not a case where you do immediate implants. If you do immediate implants in this case, I think it would be extremely difficult. So with this in mind, you say, okay, I can place 1 implant there, I can place another implant there, then I could make bridge work. That would be one option. You could place, depending upon your bone, you could place 1 here, you could place 1 here, and cantilever off 2. You could place 1 here and cantilever off. You could place 1 here. There's a whole different amount of ways that you could do this. You kind of have to make your mind how you're going to do it prior to getting started based on the foundation that you have. So this case was probably done many years ago. And this particular guide, I don't want to confuse you, but this guide was my original idea. But since then I've changed it to make it much, much easier. So this is a lot thicker. This is made on a BioStar machine, and it's 2 millimeters thick. So you destroy the model when you make it. And then this whole thing is vacuum formed over the top of a cylinder that I positioned in the mouth, in the model. So I'm going to go right through here, and I'm going to go right through here. I'm going to have a drill stop on my drill. This guide is rigid, it's not going to move, and I'm going to go exactly where I want to go, where I can then position that implant, because in this particular case I did have the bone that allowed me to go to the trajectory that I wish to go. I'm going to screw in a solid abutment, take an impression, and make a bridge, and that's it. No custom abutments, nothing. So I flapped it open, and this is, and what happens is sometimes from where you're to here, there's the tissue has a various thickness, but you can see that this is a 12 millimeter, placing a 12 millimeter implant in here. So my drill is down here, 12 millimeters. This guide is rigid. It's controlling because this guide is 0.25 millimeters greater in diameter than the outside diameter of the drill stop. So it just goes right through The same drill stop works with all the different drills, 2.2, 2.8, 3.5. I can even have a different one that works with a 4.8 also. But I mean, you can't miss like this, providing you have the bone. Now, if you don't have the bone, and let's just say, for instance, you would perforate out here, then you have to do, GBR, grafting, and associate with it. Or the other thing is, in a case like this, if you did have a CT prior to, and I'll show you, you could have the CT, a scan appliance, and know for sure exactly where you are and not have to make your flap near as wide. So here's where it healed up. I got my implant in, because you could see how much space there was. So in reference to me getting my implant as low as I need to in order to aesthetically create a decent look there, you screwed in 2 solid abutments and took our impression, and that's her final bridge work. So again, this whole concept of making your guide, starting with the end in mind and working backwards, allows you to get the implants in a position where you can prosthetically be fairly straightforward with your prosthesis. So here's a case, same thing. All right, we're going to do a diagnostic wax up. We're going to determine this is where we're going to place our implants. Diagnostic wax up. I'd like to place one here, and one there. And make one piece that fits over the top, cantilever off here on 3 abutments. And if I could use just stock abutments, that'd be great. Didn't have to make custom abutments. So we're going to put our implants there, which corresponds exactly in the mouth, because the guide that you're making is at least able to snap over your existing teeth. You just go right through that guide, and when you're done, you should have the implants in a position that's easy to restore. So here's the guide in place, and there's all different kinds of ways you can make your incisions and do that. I, came up here, flapped it all. When you can make your releasing incisions out of the anterior, sometimes it's good you could extend it around the cuspid if you wanted to, and then relieve it. There's different ways. So your drill goes right through there. The diameter of the drill stop keeps you centered in there, just almost like a drill press. So then it's easy for you to prosthetically create your final prosthesis. That's our final prosthesis. So again, this is another picture. The drill stop. This is a 12 millimeter drill stop. I'm drilling down 12 millimeters, and when my stop hits the bone here, centered in here, I'll be in the exact position that I want to be in. So this is the finished implant. This is the guide. There's the other implant there. But they ended up in the position that I wish for them to be. I'm fortunate that there is a solid abutment. Screw the solid abutment in there, make the crown bridge work over the top of it. So there's the end result. So I had, from the diagnostic wax up, determine what you want. I'll place one implant there, place another one there, place another one there, then I have one piece that fits over the top. So depending upon availability of bone, there's many ways that you can do that. That's why it's very important that the person that's going to be restoring the implants, if you're not the person that's replacing them, everybody's on the same page, and it's also a way in which the laboratory can be involved also, so there are, no surprises. So now this is a way that you can do everything on the model, go into the mouth, place your implants in the mouth, have something made and then place it in the mouth immediately. So, you know, they talk about these all on four, or teeth in an hour, or teeth in a day, so to speak. This is a way of which you can do that, but you're doing everything on the model before. Now, this particular case, these 4 incisors were coming out. The demands that were placed upon me were, I can't, well, first of all, a totally apprehensive, nervous type person. I got to be asleep when I do. So we had to do an intravenous sedation, so they're sedated when we place the implants. I can't go without anything. The thought of me going without any teeth, that just freaks me out, bothers me. So I have to have something in my mouth immediately when I leave. So we determined that we're going to take these 4 teeth out. I'm drawing this line on here as a reference, and this line is this point here where the tissue comes up in the cusp here. Okay. These teeth were already splinted together, holding them together. So we take a model, we pour up the model, and then this is a coping material. It's like really, really flexible, like if you want to make a temporary on to inject, crown and bridge, inject the Biscam material in there. So this line here is my other reference line that I had. Okay, so there's a suck down of the first material. Then what we do is we suck down another material on top of that one. And this one is thicker. This is a full millimeter, and this is kind of rigid. And it sucks down over the top of the first one. Because if you want to make something out of acrylic, it'll bond to this one, but it won't bond to the coping material. Plus, you inject into that soft, flexible one, it gets distorted, so this kind of holds it all together. So go back to the mouth after we have those 2 things down, and then we cut it off because we determined there's where we're going to put our implants. So we take polymethyl methacrylate, we put it inside that, and that's what we would like to have. We're going to put back that in his mouth when we're done, for his temporary. So I go to that, and we design where we're going to place our implants so we know this will fit back on top of the model. So I go into the mouth, and it slides a little bit out of sequence, whereas I drill with my drill stop, I go down, position my implant where I want it, take this tray material, so I have 2 of them in there, mold this around. I drill through here with a rather large burr, so when I take this out, I take this off, I can drop an analog in that model. So this is such that I can drop an analog in there. Then I can take some temporary abutments, put my temporary abutment in the model, and make my temporary on this model, because then this comes off, goes into the mouth, I'm going to extract the teeth, I'm going to drill down through there, I'm going to screw in my implants, I'm going to take my abutments I already made on here, I'm going to put them in the patient's mouth, and then pack that temporary to that in position, and then they can leave. So these are Blue Sky bone level implants. This is a temporary titanium abutment, and this is acrylic. So my analog is in here, it drops down, this is acrylic. So I make these and cut these down, so when I go back in the mouth, the only discrepancy might be the vertical. Then I can take that temporary shell that I have and put some acrylic on it and just lute it to it, and he can walk out the door. So there's my 2 titanium temporary abutments with the acrylic added to them. So in the mouth during surgery, I'll be in this position, then I'll take this and I'll just add some acrylic and lute it to it. Here are my screw holes. Then this will be a screw retained temporary. So he's going to come in, we're going to extract the teeth, we're going to put that in, He's going to walk out and we'll be done, and he's just going to wear that for 6 months. Then at the end of 6 months, we make our final prosthesis. So this shows the temporary. He wanted white teeth, by the way. He still has to do something about this. This is, you can see the sutures, gut sutures, so you don't have to go back in and cut them. And this is after the extraction of the teeth and placement of the implants, and it's temporary at day 1. Okay? This is 6 months later. And, you know, we did get some shrinkage here, but you got to take in consideration where this is. This is like clear down here. And I explained to him that he may see a little bit of metal. But then again, this is the temporary. And so this is screw retained and it comes out. So this one is rounded, it's non-engaging, and this one is engaging. It helps me reference it back and forth in the mouth. So after 6 months, you take it out, and that's what he's got. And then from here, we're going to make custom abutments, like an implant level impression, make custom abutments, and then put our final bridge work in. So, I mean, if you wanted to be critical, I could have reduced some bone and got my implants vertically deeper, but at that position, I'm not concerned about it because we're looking clear down here. So this is another one that we did it exactly the same way. The 4 lower incisors come out. There's the model. There's my surgical guide. Again, the guide fits over and gives me my reference points of where we're going to place the implant. There's the temporary, which is not really a work of art, but it sufficed. Again, you want to have these temporary, so even though these are splinted together, when I have multiple ones, I'm not concerned about any loss of the implants because they're splinted together. Single implants is much more difficult to do. So that's where it all healed up. There's custom abutments, and those custom abutments are opaque, they're metal with a UCLA type, and so even if you do get a little bit from taking them on and off, a little bit of recession, or you don't bury the margin deep, you don't fully see it. This, you can see this here, but it's white, it's not dark. And that's the final bridge work. So if you wanted to take this whole concept, this whole way of doing things, and you wanted to add another dimension, which would be to know that when you start right here and you go this way, when you go in with your drill, you're going to be in the housing of bone, totally. And as long as you're in that axis, you could do it blindfolded and not at all have to be concerned about going out of the bone. The only difference is this depth here. You either have to have a stop built into your guide, or you can have a stop built into a stop on the drill stop that stops you against the bone. Because sometimes even on the CT you got to calculate all that. So it's, or let's just say for instance you go get in there and you open it up and you want to do a little ridge modification. If you do a ridge modification and your stop is built into your guide, then you're not going to be at the same vertical position of your implants. So here's a case where I didn't know exactly what I was dealing with there, and I was a little bit apprehensive just from a regular x-ray, the way this ridge looked, and I didn't know, where am I reference to my mental nerve? Where am I to my inferior alveolar nerve? There's some unknowns there that I didn't want to play Russian roulette with. So here's what we did. This is a suck down material. This is where I want to place one implant, and this is where I want to place my other implant. and this is gutta percha. So it's my what's called a marker. So you just put that in the mouth and have the CT taken. So you put that in the mouth and have the CT taken. So then when you look at your CT, you can see exactly where you are. So here's my CT. So this and this correspond to this and that. So I knew that if I go down in this general area horizontally, I can go down this far, I'll be away from the nerve, and I know what my lingual undercut is. So this was a different type of implant planning software that I no longer use. I use a blueskybio plan now. But, you know, this is where your vital structure is. So, I didn't have a CT generated guide, and I really didn't make a surgical guide. I just made my incision, opened it up far enough, stick this elevator down here on that CT, you know, you can see that lingual undercut. So I just stuck this down here. So I keep that as my reference, and then I just drill down, and I know mentally that what angle I have to drill. And you've got your initial pilot hole is a reference, and then you've got that. So then you place your implants, and then you just close it up. And this is healed up, and this is a solid abutment in place, and then there were 2 implants. Those were 3.3 millimeter implants, narrow diameter implants, and so we just splinted them together. Another way to do this too is with the maxilla. Okay, you don't know where this is, base of the sinus. You can come up where you're drilling, and then you hit some resistance, you feel where you are, and then you stop, and then if you want to lift it, you can use a osteotome technique to do a sinus lift. This guy was retired out of the military, and he was a pilot in the military, and so I told him, I said, look, you use your instruments when you were flying your plane, because you always believe your instruments, right? He goes, yeah, you always believe your instruments because, you always believe those. I said, well, I need a reference point to where we're going to drill. So you're going to have this scan done, so it allows me to know exactly where I'm going. Just like when you're landing your plane, you're looking at those instruments, you know where you're going, you believe those instruments, because this X-ray, type of X-ray doesn't lie. It's one-on-one and it's perfect. It doesn't, whatever it says is what you have. Just like your horizontal on your instrument tells you exactly where you are. So that same concept where you do the suck down material. This is my gutta percha marker. With my gutta percha marker, so I do my workup, and I decided that I can place a 4.8 millimeter implant in there, wide neck implant, and not be concerned about the sinus because I'm going to be away from the sinus. So there's my 2 implants in, and I mean, it looks like, oh, what do you have to do? Did you have to do a sinus lift there when you put that in? No, I didn't have to do anything because I had my CT, I stayed inferior to the sinus, it drilled up. I was totally relaxed when I was doing it because I didn't have to be concerned about anything because I had my CT and I had my marker. Now, if I would have been drilling back, different position horizontally, because when you've got that marker right here, you know where you are. So there's our finished crowns. So, I mean, if you want to take it, okay, we want to go a step further. So what we want to do is we want to make our guide and have it CT generated, maybe have a CAD CAM generated, maybe do flapless surgery, not even lay a flap. But I'm not a big fan of flapless surgery. I like to lay the flaps anyway because I like to bring all my tissue over to the labial to allows me to get a better soft tissue end result. So this would be a guide generated from the CT. And I'm still going to use my drill stop. The guide's going to be made of a certain diameter and that allow me to use my drill stop as a guide. So it eliminates the guesswork, you get improved placement, safety, and reduces your stress when you're placing the implants. Now, of all the implants that I place, doing it this way, less than 5% of the time. Because there's only 5% of the time that I feel that I'm working, and I'm close to perhaps structures that I need to have that information. Now, there is a school of thought now where they say, well, this is the standard of care, and you have to have a CT before you place any implant. Well, I mean, there's a number of implants that I placed in 20-some years, opening things up, drilling down, taking an x-ray. Yeah, maybe if you had the CT, you would not have to be as cautious about what you're doing or increase the speed a little bit, but personally I don't think sometimes the expense doesn't justify doing that for the patients. So, again, with that CT generated guide, you got this opening. You know if you go through that opening and you drill, you're going to be in a correct position. So, I've done a lot of these where this is my surgical guide, that's my opening, same thing, I drill down. It's model based, it's not CT generated, and it's a lot less expensive in order to make it. But for these, you got to go through some extra steps. You got to make this scan appliance. You have to wear the scan appliance when they take the CT. Then you have the fabrication of the guide. So this will be the last case I'm going to show. Here's your wax up. We decided that, and economics is such that we're doing this side this year and then maybe doing this side next year. So as a wax up, determine, this is what we'd like to have. And from this is a scan appliance. The scan appliance is made with the teeth in it. These teeth here are coated with barium, so they show up a certain way on the x-ray. There's different protocols for doing this. This is the gutta percha for a marker, because this was going to be done with the Blue Sky plan, where everything is joined together to make the fabricate to do the guide. So if you want to do it this way, you have to have a CT taken with that scan appliance in the mouth. So if you can remember, right there, there's our guide. There are markers. This is what will show up on the CT. Here we are. So here's our final position. Here's using the Blue Sky plan to make determination of what implant we're going to place in the different locations. And this is all mapped out. This is all done on a computer beforehand. This is the first implant that we're going to place right here. And then this shows the depth and all that. So you look like, oh well, boy, you could drill out this way, but with this approach, and that guide is made, you set that guide in there, you go right through the guide. When you go through that guide, you're going to stay within the bony housing. You're going to be within the bony housing 101% of the time. So here's the guide. This particular guide is what's called a printed guide. And so you can see the openings right here. And I don't have to come from the top down. I can slide my drill in through the side. I can take you could do this fully flapless if you wish to, but in this particular case I flapped it, so we're going to put one implant there and one implant there. So that's the way it looks like in the mouth. Here shows the drill stop attached to the drill, going down through there. There's the implant position. This is a 3.3 tissue level blue sky implant. So this shows the implant, where we planned it. There's the osteotomy before we have the implant. There's no guesswork with this. I mean, again, I showed you cases that look just like this, only we did it on a model. We didn't do it on a CT. So you could be off on the model, or you have to put that guide in and flap it open to verify where you are. But with the CTs, you have this so you don't have any concern. So there's my two abutments. Close it back up. Again, if you wanted to, you wouldn't even have to open it up. You could just drill through and screw in your, so there are the implants. You can see how parallel those are to each other, perfectly spaced. And there's our final bridge work. So I got two websites. I've got a drillstops.com website. This is my office website, and if you wanted any other information or if you had any questions or anything about this material, again, this is on a PDF form that you can get from Johnny. He can give it to you. Any questions or anything, be happy to entertain all those we're showing. Okay. Does anyone have any questions on anything? On any of the stuff that we've discussed thus far? Come on, somebody's got to have a question. It can be a stupid question. What's for lunch?
You first question, how do you change your aim? Clear guide 的话 you can that way you must clear 出偏向于那个有没有翻译？刚刚有那个有一个设计，就是说今天角度是偏向它是不端向的。
Okay, when you're making your guide, if it's model based, not CT generated, on a CT generated guide, you never have to change your course because it's generated from the CT. You know the bone and you do the plan, so you know you're always going to be in bone. If you do this model based like some of the other ones, you may have to make an alteration, but you're going to have to use your common sense, but at least you're going to be in the correct horizontal position. Buckle angle, you may have to change your angle, but you can do that just as you're drilling. So sometimes you may start using the guide and then not finish using the guide, because you might have to make an alteration. But if you want to eliminate the need to do that, then you do it this way with the CT, because you never have to change, because it's the opening is made from that CT that you never have to change your course. Did I answer that question for you? Yes?
In your cases of anterior bridge
Wait, what's that? I don't know, it was up here, it's not here. Huh?
In your cases of anterior bridge work, you have two cases. One case is about lower 4 incisors. So you do the temporary fixed bridge immediately, right? And about the 4 missing upper incisors, I would like to know what kind of temporary bridge do you use, and do you fold the tissue? Thank you.
In the upper case, what I used was a removable, like a flipper type. That's one way. A second way, are you familiar with what's called an Essex retainer? Sometimes you have a coping that snaps over, and then you take the ponic region and you fill it in with acrylic. And this afternoon, I'm going to show you some of those.
Thank you.
Mm-hmm. Any other questions? Okay, How many have done CT generated surgery? No one's done CT generated surgery. So that last case, none of you would do it that way, ever. Or you might. Have you done it? You haven't done any CT generated surgery? Okay. But you make the guides off of that, or you just use that mentally as a reference? Okay. No more questions? Were we supposed to finish around 12 o'clock?
12:30, I think.
12:30? Oh, I thought I was supposed to finish at 12. Okay, well, let me start on some of my other stuff then. Sorry. Let's see here. We're going to go through this. No, I got a couple more things here I want to show. Johnny?
Yep.
I need a translation if I want to show this video. How do I pull that up? Yeah. Okay. While we're here, I'll show you a case. So in this particular case, this is going to be immediate placement of 4 lower incisors. So you can see that we're sectioning the incisors. Painless extractions due to good anesthetic. You asked about a temporary. Here's a Essex type temporary. So I'm just kind of adjusting the temporary to hitting on the mesial of those cuspids. So this is what the patient's going to wear for the interim period of time while we're waiting for the implants to integrate. Another way to do that would be to use removable. And I like these because you don't have any pressure on the area. So in this particular instance, we're making a little incision here to reflect the tissue. Now, I'm going to go in and after I reflect the tissue, I will take a round diamond burr and smooth out the ridge. Now this is my depth gauge, and there's a 1.8 millimeter collar right here. So I'm taking that and I'm putting that into the base of the socket. And then I pull it out. And that's a 3.5 millimeter collar that's on there. So I know that when I place that gauge in there, I pull it out and say the gauge is, well, the line says the socket depth was 8 millimeters. Then depending upon how far I want to drill, for me to get stability, I make an adjustment from there. And this shows the drill stop on here. And in this particular case, we're going a 12 millimeter implant, and that takes me right down. Now, what I like about using the stop is when I'm drilling, I don't have to look for any line. My eyes are focused on my placement. Then I just verify that with the collar, so that shows me where my platform is going to be, whatever length implant I put in. So then I just go up through the drill sequence. So when you take that tissue and you fold it back, if you think you want your platform a little bit lower, then you can just maybe make an adjustment in the burr. So in these immediate cases, you're not drilling really fast, you're drilling slow. And you can see that I'm trying to focus on keeping the direction of my drill. Because you don't have to look at all for the lines, because you know what you want to do, and you can verify with it. You want to go down to a certain depth, and then when you screw your implant in, you know where your platform is going to be. And I didn't use a surgical guide in this particular case. What we did is take and adjust. In this particular case, tap the bone prior to placing of the implants. It just so happens when I made this video, these are Straumann implants. Do it the same way with Blue Sky implants. This is grafted material. When I do immediate placements, I take and I fill my socket up with that grafting material, then I screw in my implant. And that it's just like powder, it's so fluffy, it just conforms to the socket. I don't think you have to fully fill it up. So this just shows using the Straumann implant, whether or not you're using that one or Blue Sky, and then if you're interested in seeing any of these, I got a page on YouTube. It's Emoverbin DDS, and I have all these videos, and I have some other ones on YouTube. You can hold them down. I think on this one I've got my final prosthesis too. If not on this one, I'll have to get my other one. The other video. Close it up. Put her flipper in, and then she's on her way. This particular patient here, after doing this, then a couple years later, we did her whole maxilla also. Okay, I don't have it on that one. I have one other one to show you here.
Excuse me, I have some questions.
Oh.
Okay, first, sorry, some stupid questions. I'd like to know what is your procedure of this slow drilling protocol? Because it is not so familiar.
Low speed drilling?
Slow speed drilling. Yeah. Maybe with water, maybe 20 to 30 RPMs. And what is the indication of this procedure? Why do you like to use slow drilling?
Okay. How many people drill with no water? Good. Many times I drill with no water. Why do you need water? Because you're going to heat the bone up. If you go low speed, you don't heat the bone up. And also depending upon the type of drill you use also. But the lower speed gives me more, you think not, but it gives me more control.
Control.
Especially in extraction sockets, it gives me more control.
Control of what?
Just
Direction?
direction,
Okay.
control of the direction. Basically, that's the reason I do it for control, direction. Now, in an extraction site is different than in a healed ridge. I don't drill that slow in a healed ridge. It would take you forever. But I'm probably going around 100 RPMs.
100 RPM? I don't think it's 100 RPM. I think it's
Maybe 50.
Maybe 50 to
50 to 100.
Okay. It's very slow.
Yeah, very slow. There is a drill that's out that I use. It's made by Osseo. It's an Osseo drill. And they did a research project with that drill versus Zimmer drills and the amount of heat generated. And all drills develop a different amount of heat based on the cutting flute design. And they advocate drilling under 600 RPMs with no water on the drill. There's a technique from a dentist from Spain that drills all with no water. And then when you drill and you take the bone accumulation off of the drill and use that as part of your graft to pack back. So.
You decide your equal the Parker-side bone under the Parker-side bone position. Immediate implant, you touching these two teeth. Right down your three. How deep you decide?
How deep do I decide to drill?
Under the Parker-side bone, all equal the Parker-side under.
If my depth of my socket is, just say, 8 millimeters, I usually drill about, well, it all depends. Because you can start to create stability. You don't have to go through the apex for stability. You can gain stability halfway up the socket by putting a larger implant in. So you may start to get stability starting at 5 millimeters into the socket, on the lateral walls of the socket. So, but I usually go about 3 millimeters deeper than the depth of the socket. Four.
You usually implant inside the socket. You usually put how deep you under the Parker-side bone enable.
I am not below the buccal bone. I'm above it. The polished collar is right about starting at the curvature of the bone. The polished collar.
Just equal the bone nail or under the bone nail.
Well, if on the tissue level implants, it's a little bit higher than on the bone level implants. Bone level implants are submerged to probably 1 millimeter or 2 millimeters below the bone because you're going to get some shrinkage on that. Whereas in the tissue level implants in the extraction socket, the bone fills in. Now you can put the bone level below and then you can place some grafting over the top of it, do it in a 2-stage procedure. But all of these I was doing as a 1-stage procedure.
Me.
Yes?
Another question. What is the content for the part?
It's demineralized bone. It's a human bone. Demineralized bone that's been irradium treated, processed to eliminate all disease transmission.
On the socket, in the socket.
Makes me feel more comfortable. You don't have to, but I'll show you the anterior cases that I like doing. We don't have time, I could show it. You got time to show the anterior case? No, I'll show it after this afternoon.
You can show it. You can show
Huh?
it. Yeah, you can show it right now.
Depending upon how much space you have, if it's greater than 2 millimeters, I graft. And in this, so you graft so that when you screw the implant.
Usually we put the bluegrass after the fixture is fixed.
Fistula?
After the fish. You like your bone graft put in the socket. After the fish or fixation or before.
I put it in before.
Before.
It's not, it doesn't affect the placement of the implant because it's so soft. It's not hard. It's not granular. It's really, really soft, and then it just conforms and around it. In many instances, I don't put any at all in, but I do like to put it in on the up towards the top instead of packing it in. You just put it in before.
Okay. Thank you.
Why did you choose DBA?
I'm comfortable with using that. It has a faster resorption rate, replacement rate. I don't use BioOS much, or pig bone, and what's called BioOS.
What did you not use bio?
This is, I think, as effective, and it's easier for me to handle. This is very nice handling because when it gets bloody, it kind of clumps together, and you can just kind of make a mold it like putty.
It's not because the rest of the material.
No, I think all the materials work.
So even HA, PCB.
There are some cases that I just use tricalcium phosphate. I don't even use any grafting material at all. I mean, use that for my grafting material. I'm not using any bone. I'm not mixing that with it.
So I was told that HA will actually get absorbed. It's always there.
HA? Yes, it is. I don't use that. I mean, if you put HA in, then you want to go back and place an implant in there, you're going to have, it's not a good situation. I'm sorry, but my computer does not, for some reason, work with Visio, so I don't have, I could show you exactly the finished case, but I can't show you because it's not on, I don't have it on my jump drive. Do you want to take it now? Do you want me to show you the other video? Last not even 5 minutes. That's it.
想要了解他们作业会讲的东西。现在刚才有讲，我不知道，有去讲的，刚下就下，这些
Nope, I just showed that. Okay. Okay, here's another, people are asking me about anterior placement. This will be an anterior, immediate placement. So I like to use the luxators. So in this particular case, we're going to put a narrow neck implant in. So extraction and then thorough debridement of the socket, remaining any periodontal ligament fibers, and then irrigate the socket out, and then there's my depth gauge. It's showing me this. I'm trying to make a determination on what length of implant I'm going to place. So I'm measuring the base of the socket, determining where I want to have my implant platform, and then making, because this will go up and down. This is 6, 8, 10, 12. I spin that down. I make all my measurements. I put this in, and then so I can make a determination on what implant length. So when I'm done finishing placing my implant, my margin of my crown is going to be on the platform here, so it's going to be down. Now, if it's further, then we can make a custom abutment to raise up. In this particular case, we got a situation where we're going to end up making it a screw retainer restoration because of the vertical clearance. Now, sometimes by using that gauge, I will take and make a determination that I have to remove a little bit of bone so I can lower my platform and drill deeper. So this just shows where we started here with the extraction, and I've made my determination as to where my final platform is going to be, what length of implant that I'm going to be placing, and then placement. Now, most of the time in these anterior cases, you're not drilling through the apex. You're drilling on the lingual wall. And to drill on the lingual wall is difficult unless you create a purchase point so you can start drilling. You can't start drilling with your spiral drill on that lingual wall because that drill is going to walk all over on it. You've got to create a ledge or a spot in order to start. So you're going to have to drill, start drilling at an angle, and as you drill down angly, then you upright it, and then you control it, you continue to go apically. So drilling in extraction sockets is a little bit more difficult. So you can see that I'm making a determination. I'm trying to show you here that that's the angle that you have to do. And in order to drill like this, you have to first do this. You have to create something in the palatal wall, because when you end up with your implant, you're into the palatal wall. And basically, I tap. So here's my round burr, and you can see the angle. See how the angle's going? Round burr creating my purchase point, and then from that point, I'm going to start with my drill. And I know here that you even have to be even more precise, I think, with the Asian population because of the shape of the premaxilla. This is even more critical that you do that, but just allows you. So there's my first implant, and I'm kind of making my decision on where my implant platform is going to be in reference to the tissue, and then I can make a determination on what implant. Now, again, when I'm drilling in this, I start, stop with the drill, and then always, every time, you got to tap that lingual bone. You have to tap it prior to placing of the implant, because it's going to allow you to control that horizontal position. Then again here, this implant is going to be way to the lingual. So that's my demineralized bone matrix, and I'm placing that in, and then I'm taking a curette, and I'm filling that space in, and then I'm screwing in my implant. You can see how far I am to the lingual, and how much room there is there. This just happens to be a strong and narrow neck implant. You can see showing you the insertion torque that I've got there. I'm probably about 25 Newton centimeters. Now, this case I'm showing you this afternoon, this person had a kind of a thick biotype, but sometimes you take your periosteal elevator and you separate, you create like a pocket between the labial plate of bone and the tissue, and then you stuff grafting material into that pocket to plump out the tissue. Now this is the Essex retainer that he's wearing. This is the implant in place. So that's when he walks out, that's a day of surgery, this is 4 weeks later. And these little peak healing abutments keep the tissue supported against that to help maintain it and prevent it actually from shrinking. So then we're going to take an implant level impression, open tray technique. And I make all my soft tissue models myself in the office. And this is a polyether material, so I use a polyether material injected over a polyvinyl, and it doesn't adhere. This material is made by ESP. So just inject that around there, and then take a moist cotton pellet and pat it. You send this to the laboratory to make it, I think they charge you about $75 to make this soft tissue model. It only takes 5 minutes to make it. Pour up your stone model, separate it. Here is, again, there was a total lack of space here, so this is my off, and this was going to be a screw retained. So there's my screwing my crown in and testing the contacts and all of that, and torquing it in, and then we take that and close that up with X-ray to verify everything is down. And then we fill that back of that in with just composite restoration. Torquing it down. I torque mine to 35. Seal the lingual, there's the screw, seal it up. And we're complete. Now this was the day I seated it, and this actually is all filled. I have another photo that I can show you, because if you make your contact at the correct point over time, that tissue will fill in, provided you have a certain distance. Okay. All right. That's it. We'll be at lunch, and then we'll come back later.